Hey everyone, I have the pleasure of being joined by Dr. Kyle Matsel. We get tons of questions about our ACL reconstruction rehabilitation courses on MedBridge, where we take a person from early stage rehab all the way through performance. And one of the questions that we get surrounds kind of return to sport timing or discharge from rehabilitation timing, where we've talked about in the course that, kind of 9 months is probably our minimum that we should look at before returning to sport, sometimes even up to a year, but certainly rehabilitation being a full year process. How do you navigate working with the physician who says to the patient, even before surgery, you'll be back to sport at 4 months or 6 months, or you'll be, done, you'll be better at 6 months, you'll be full good to go. Yet we know from the research and we know from our best outcomes that it probably is 9 or 12 months, but yet the surgeon did the surgery. How do you navigate that? That's kind of a touchy subject.
It really is. It really is. I really appreciate the question because it's real life, right? People are literally dealing with that all the time when managing these athletes. And, the physician you got to think the physician is in a little bit of an advertising, a little bit of a marketing mode too, because there's obviously competing physicians, maybe in the same town or same community, same regional area that are doing ACL reconstructions as well. And, if you have one physician A who's saying, hey, I'm going to get this person back to sport at 6 months, and physician B says, well, it's going to be a year for us, and from a patient or an athlete or a parent standpoint, which one are you going to go with? And from a superficial standpoint, it sounds really good. Just say, oh, I'm going to definitely go with the person that can get me back the soonest, right? And I think it sets rehabilitation up to sometimes be a little bit hamstrung a little bit. The expectations then are you're going to be back running in 3 months and 4 months and jumping, and then back to sport and discharge 6 months. And we know that that's not always the case, and most of the time is not the case for our athletes. So the conversations that I tend to have with the physicians really are geared more towards the individual patient and how they're doing in rehab. And for that, you really have to have very clear, objective measurements, biomarkers, milestones. You have to come with the physician with some reason or some data, right? If you just say, is this not ready yet? Or, yeah, we really need to just get to 9 months, even if that's what the research says, that's a hard sell for the physician who did the surgery and really has a ownership to get them back, right? So I think that's where doing lots of testing, getting lots of information, saying their power is down, their strength is not quite where it needs to be, and having that plan in place can be really powerful.
Absolutely. I think in addition to that, I think that communication early and often, and attacking that communication really on two fronts. One is doing some education with your physicians and saying, let's talk about how you can talk about this with your patients. Here's the research that says 9 months really reduces re-tear rate. And maybe they can talk to their patients about, hey, you will, most physicians, and including my surgeries, you can kind of go back at 6 months, but we have to understand the risks involved of that versus 9 months. So that's one area that I kind of talk about with the physicians. The other one is those biomarkers, like you said, is let's agree on those biomarkers and say, let's put these down, that, this is what strength is going to be. This is what hop testing is going to be. This is what your balance testing is going to look like. This is what your movement's going to look like. This is what endurance and power and agility and all these things are going to look like. And let's agree to those in advance with the physician. Then I kind of think about it then, okay, that's one area of education. And frankly, sometimes that works, sometimes that doesn't. I mean, it really depends on the physician. I find the better relationship I have, the better it works. But the other thing is with my patient is, I don't go against the physician. I say, hey, physician may have told you that, you're going to be ready to go at 6 months. That's from a surgical perspective. That's from his perspective. My role is the rehabilitation, and my role is to help you with that process. And so here are the biomarkers that we're going to be looking at. And also here's the research about returning earlier than 9 months. And I'm not saying that that's an absolute no-go on before 9 months, but boy, we all need to be on the same page about risk of re-tear, risk of tearing the opposite ACL, and what that actually entails, and what does long-term look like. Because the one thing I think we have to recognize too is there are certain situations where I will return someone before 9 months. Obviously, easy one to say is, senior year, to be able to complete that senior season. They don't plan on playing in college. My goodness, yeah, we're going to try to get them back as safely and as effectively as possible, but we're going to balance that risk. Do you have any thoughts on that?
Yeah, I mean, I think that the negotiation piece a little bit is nice with the patient, and it's like, hey, we are setting you up for a 6 month or a 7 month plan because you need to get back for your senior season, but just keep in mind that things can change. A lot of variables can happen within that time frame, and if your power isn't where we want it to be, if your movement isn't where we want it to be, if your pain isn't where we want you to be, then we may have to extend that a little bit more. So again, it's a little bit of a motivator too for the athlete, but they always are kind of aware of, if I do choose to go back earlier than we would feel comfortable with them going back, that there is a little bit of elevated risk. Now, the other mistake I think we make in rehab sometimes is we say, oh, you're back to sport, therefore let's just stop seeing you in rehab.
Right.
And I think that this is really the clear discharge and return to sport is not the same thing. And this is a perfect example of, okay, you're a senior. Let's go ahead and start getting you back into some limited minutes, into playing time, so you can have that senior year. But at the same time, if you're going to have a problem, I want you to have a problem while you're still under my guidance and my tutelage, because I want to be able to mitigate those problems and continue to advance you in the rehab process throughout the entire duration of the plan of care.
Absolutely. Well, some great thoughts. I think the key thing is we need to, bottom line, educate our physicians, educate our patients, and ultimately, as a team, we're making that decision. But I don't think we should just step aside and go, oh, well, that's what the doctor says. So great answers there. Great discussion. If you have any other questions, don't hesitate to reach out to us. We love answering questions. If you haven't seen our MedBridge courses on ACL reconstruction, rehabilitation, or performance, check those out. We have a lot of fun doing those, and absolutely feel free to shoot us questions.